Hey everyone, this is Victor from Cyborg for Life, and I want to welcome you to episode 137 of Limb Lengthening Live, where the patients interview the guests. And today we are doing our monthly live Q&A with a world-class surgeon. We have Dr. Robbins joining us again from the Paley Institute. Welcome back, Dr. Robbins. How are you doing?
Very good. Very good.
It's good to have you here. All right,
Nice
guys.
to be
So
back.
it's always great to have you. But before we start, we said last time that I had to ask Dr. Robbins for our mascot, Marshall. He sent some
Yeah.
good old pictures in here, and Dr.
Yeah.
Robbins sent me some over the weekend here of his beautiful wife Holly and our mascot Marshall. So look at this. Tell us about this photo shoot here.
Yeah. So that's the backyard. We took a bunch with me and Marshall, but I couldn't get him to be awesome like that. So we'll dress up. Hopefully, well, definitely by the next time we do it. But for next week.
Yeah.
We're hosting a Halloween party. Holly likes Halloween and 4th of July. So we're going to have about, I don't know, probably 100 people throughout the night, but we have a band and I'm starting my meal cooking tonight. I got 100 pounds, 15 rack of ribs, 30 pounds of pork, 2 briskets, and I think 20 pounds of sausage I'm going to start smoking out tonight.
Oh my gosh.
Yeah, so that's Saturday. So after Saturday, then I can revisit the photo shoot.
Well, it looks incredible, and that food sounds even better. So I'm booking my flight to come down right now. So
that's right. Every 4th of July and every Halloween.
Halloween. I didn't know that Halloween was your favorite.
Yeah, Holly loves it. The house. I don't know if you can see what's behind me. The house is crazy. Holly
decorated.
Spends a month decorating. Yeah.
That's incredible. That's awesome. All right, guys. Well, I will actually decorate the banner. I'm going to put a banner here. So next month we're going to have like Marshall all over the place. But all right, guys. So we're going to get right into it. I have I'm going to share my screen. We have some questions that were submitted.
Okay.
So let me take this off for a sec. Let me share screen. And besides that, Dr. Robbins, any other little escapades in your life since the Denmark trip?
No. So I don't know, when we were chatting with the person offline, I keep looking at my foot. I went for an awesome run last night, and I have my old running shoes that are very worn in, which is great. But I had a little crease in my sock, and I just ignored it. And after a 2.5-hour run, it is now a blister right on the ball of my foot, and it's so annoying. Like I'm debating popping it or not. But yeah, I had a good run. I haven't had a long run like that in a long time.
Yeah, he told me, guys, just, me and Dr. Robbins are pretty cool. He told me in messages that he ran 12.5 miles yesterday. I was like, I don't even want to drive 12.5 miles.
I don't run with a watch. Had I known it was that distance, I would have gone another 0.6 and called it a half marathon. But I just kind of go while I feel. I listen to John Steinbeck of Mice and Men on double speed. So that's about a 2-hour book. And then I listened to some podcasts. And it was great. It was just rainy and like 98% humidity. It was a slog. Oh. But I did it. I'm done. So that was good.
I'm done. And then you probably worked a full day of work at
I worked today, got up and worked out. My legs are a little sore.
He is a man of many talents. I love it. And he is here to answer your questions. So, all right, Dr. Robbins, we're going to go right into these questions that were submitted here. We got the first one. Can internal nails that are used in legs be reused for the arms if they want to get humeral lengthening?
Short answer is no, because the leg nails are usually the larger nails, the 10.7 or 11.5 or 12.5 or something, and the arm nails are usually smaller. They're usually the 8.5. You don't need a very big nail, one, because you're going through the rotator cuff or very close to it, and 2, you're not weight bearing on your arms. So in theory, you could, I suppose. The problem is the nails are not designed for multiple use. So if you take an extended nail, then you have to compress it after you take it out, which even with a rapid distractor could be a good 15 minutes. I don't know how long that would take. Meanwhile, if you run it for that long, you're probably heating it up beyond what the tolerances are for, and then you're going to put it back in and hope it works. And then you worry about sterility issues when it comes out, what if screws thread. So in theory, in an emergency, for whatever reason, yes, you could, but that is super off label, and we're not doing it.
You're not doing it. All right. I like the technicalities, though. I do like that. The possibilities there. All right.
No. We talked about this. No, there is no benefit to doing that. No. Because who knows what's going to happen between surgery 1 and surgery 2, and there's no guarantee everything's going to go well. So I know we talked about there's another surgeon who does one and then a period of time does the other leg. That's not how we do it. We do both at once. It's the risk of going under anesthesia twice as opposed to one anesthetic. Our danger incidence, which is the fat embolism, is incredibly low. We haven't had a case since COVID. Our 2 cases were during COVID and had some association with vaping, which we're all over now. And when we interview our patients, and you and I talk about that all the time, the pain is there and the pain goes away. Sorry to say, it's uncomfortable, but that's why we keep you in the hospital. We give you strong pain medicine for a couple of days, and you get through it. It's part of the process. If it were easy to do and it didn't cost anything, and anyone can take 3 months off, then everyone would do it. But there's got to be some buy-in. You have to understand this is a big deal. If it's too easy and too seamless, and you just sort of show up like a nose job or an augmentation or a facelift, and I'm not at all saying those are easy, simple, but relatively simple, then a lot of people are going to jump into it without fully grasping the severity and the potential risks of this procedure. So no, we're not staggering them. We're doing them all. We stagger below the knee first and then above the knee 3 weeks later, but we don't stagger one side than the other.
Now, I was on a consultation recently. A patient asked me, what about doing it, because, non-weight bearing nails, doing, let's say, one femur and then 6 months later, because they can get around on one crutch as if it was a discrepancy.
How much, what if one doesn't? What if you're in a car wreck? What if you lose your job? Someone gets pregnant? Seriously, we've had a patient who had to stop and leave because they got pregnant, or they found out they were pregnant, or whatever. Now they can't get x-rays. They can't have more surgery if there's a complication. So no, you don't know what you don't know what tomorrow offers you. You have today, so make the most of it.
I got it. I love it. Keeping it even. All right, this next one here. I often hear about patients stop lengthening for 1 or 2 days to manage pain. Is there any value in incorporating stopping like once a week, say on a Sunday, to manage pain levels, and then letting the tissues catch up?
Often, yeah. Have I stopped patients for reasons? Yes. Is it for pain? No. It's typically for stiffness or nerve irritation. It's not like pain from the lengthening. Yes, every now and then we stop someone for a few days. It's usually for bad bone. Marshall, I already took you on a walk before we went, so back off. So no, every day you stop is one more day you're running out of PT. It's one more day you're paying to be here. It's one more day you're out of work. It's one more day you're from your home. Come here, do a good job. If you want less pain, stretch more. So how about that?
I love it. I love it. That's usually the culprit, is tight tissues, right? For pain after the post-surgery. Yeah.
That's right. There's nobody who stretches too much.
Yeah.
Hasn't happened yet. So please come be my first.
I love it. All right. Next question is, can you explain the difference between a superficial and a deep tissue ITB and release, or ITB? How important is it for mechanical function?
I'm guessing they're talking proximal and distal, because there's not a superficial and a deep. It's one structure and it is where it is. If you're thin, it's superficial. If you're not thin, it's deep. The iliotibial band starts on the pelvis. Which is your pelvic brim, where your belt is. It goes down on the outside of the hip where the bump is, called the greater trochanter, and then it attaches all the way actually below your knee onto your tibia. So if you feel the below your kneecap off to the side, on the outside, there's a bump. It's not the head of the fibula bone, it's in between, and that's where the iliotibial band attaches. It's a bump called Gerdy's tubercle. Everybody getting a femur lengthening gets the distal release. That's a complete transection. We cut it from front to back, top to bottom, inside to outside, however you want to call it. And that will completely grow back by the end of your lengthening. And when you come back for removal, it's going to be tight again. And then the proximal extent of that, the extent of that close to the hip, where a muscle called the tensor fasciae lata attaches to it, maybe that's what they mean by the deep. It is deeper because people have more meat around the top of their hip than they do around the side of their knee. And that is 5 or 10% of people that gets released prophylactically on the front end. It's just much less common we do it. And it's even more rare that when someone comes a year later for removal, that it's still tight. And then sometimes we'll do a release there at the time of removal. That's always an option, but I'd rather not improve you with surgery. I'd rather you just stretch more and come to me without it being contracted or tight. So if that's what you mean, then that's my explanation.
Also, when he sent it to me, maybe because he also said that like, he was a patient who got it released as lengthening went on, because he didn't get it done prophylactically.
Yeah.
And his IT band kind of like, I think he meant like superior and inferior, like if you were,
yeah, that's what I'm thinking.
Yeah. So, okay, gotcha.
Yeah. So grows back. It grows back for everybody. I mean, you can feel it like a tight rubber band when they come back. And the number of people who have had a proximal release is less than 5% of the total. I mean, I'm sure I've done 30 or 40 of them in 10 years, but I've done hundreds and hundreds of the distal releases. So it's really so rare compared to the distal release, which basically everybody gets for femurs.
Gotcha. All right. His next question about the ITB was how important, what's the importance for like jumping, running, knee stabilization?
Well, it grows back.
It grows back.
It grows back. And proximally, we often don't release the whole thing. We just release enough so that it's looser, so that it diminishes your chance for getting a contracture.
Okay.
So it's not necessarily distally by the knee, it's a complete transection. Proximally, we often leave a band in the back intact.
Okay. Now, he did see for his next, because he had a few questions here. Same thing with the ITB. He felt like his TFL was super tight when he did get that abduction. And he sent me a video. I'm afraid to show it because it might like cause some like glitching. I'll show it to you later. And maybe
you can see it snapping over the greater choke. Yeah.
Is that possible?
Yeah. My wife does that and she's never had lengthening. It's just some people's just the way they are. If it didn't do that before and it does it now, it's because you're tight. So stretch a lot, and that should loosen out. It's not a functional problem. It's annoying. Like I have a snapping, I think we've talked about this before. I have a snapping hip, which is on the inside of the groin where the psoas tendon rubs over the lesser trochanter. It doesn't hurt, it's just annoying. And if I'm doing crunches, I know to rotate my leg whichever way doesn't make it happen. And I just modify how I do crunches. So I don't think that causes a functional problem. But if it's tight, that's the functional problem. The consequence is that you feel it snapping over your greater choke, but a tight tensor makes it hard to run, hard to extend your leg. It's hard to adduct your leg. So the tightness is the problem, not the snapping or the sliding over the greater trochanter.
Okay, very cool. Then he asked about knee tightness, and he's getting some knee clicking, but it's not necessarily too painful. He just hears the clicking. How does that happen, and how long does it last for?
So did we do surgery on this person?
No, I don't think so. No.
So if it's lateral, it could be the IT band sliding over the lateral femoral condyle. That's a common thing. But some people just have clicking at the patellofemoral joint. Just like I have clicking in my patellofemoral joint because I banged my knee when I was 16 years old. And then when you're lengthening, things are under tension or compression. And so I'm sure my knee would crack and pop more until it stretched out again. So people get weird aches and pains and sometimes cracking around their knees, their patellofemoral joint, their kneecap in the front. And then as you stretch out, that resolves.
Okay. Very cool. And then the last question that we have here, the submitted ones, was where exactly, this was a father for his son's thinking about surgery. He said, where exactly is that tibial nail inserted?
It is in the front on the top surface of the tibia. It is extra articular. It is not into the articular surface of the tibial plateau.
Got it.
When we put it in or take it out.
Is that just your surgical approach, or do you know that?
Well, most people, be careful what I say here, I'll get in trouble. We put it in the right place. Other people don't necessarily do that. They start too much in the front of the tibia, not on the top of the tibia. And then that leads to procurvatum where it bends and you can't fully extend your knee, or that can predispose to going into valgus, which can happen anyway. But starting point placement and nail placement is a critical thing. And that can be easily overlooked or messed up. So it is extra articular outside of the articular surface for both placement and removal.
Okay, very cool. Alrighty, so that was the submitted question. So I'm gonna stop sharing that, and then let's see. I don't see any of the chat questions too much yet. Angelique's in there, so she's actually answering. Welcome back, Angelique. I guess yeah, she's helping us out big time. She's keeping it locked down there. But we do have a case that was submitted. I don't know if you can see that. Is it too small? Pretty small.
Yeah, can you make that a little bigger?
Great. I'll blow it up. Let me share my other screen.
I think this guy just sent me his x-rays. Actually, when I'm in the office tomorrow, I have them uploaded so I can actually do some measurements. Yeah, if I remember right. Yeah, he had lengthening, and he always felt the leg was short, and the surgeon kind of downplayed it and said, no, it wasn't. And then all of a sudden, he's now consolidated, and mea culpa, you're actually right, it is short. Is that a quick summary of it?
That's a summary. You got it.
Yeah. And so whether it is short, whether it is short or isn't short, it's a nice topic point. And we've talked about this thing a few times where you can have a functional leg length difference where your hip, your pelvis is off the ground on one side because it's contracted, and that brings your foot off the ground. So your leg feels shorter. But if you actually measure the length of the bone from the ankle to the hip, even though it's off the ground, you don't measure that part. The bone lengths are equal, but a contracture of the pelvis can give you a functional leg length difference. So I think this guy has an actual leg length difference. Whether he has a functional difference or not, I don't know, but I'll be able to measure that out. But we can use this case as a talking point for, one, how do you prevent that from happening is you have to be able to get an accurate x-ray when you're done lengthening. And I tell all of my patients this, and probably 1 in 15 we can't do it because they just get too tight and they got to go home. They're on 75 millimeters, they're leaving at 77, whatever day of the week that is, and they're able in therapy to get their knee fully extended. But to stand like that for an x-ray, their knee is slightly bent. And if your knee is slightly bent, I can't measure you accurately. I can measure the length of the nail distraction, I can measure individual bone lengths, but I like a standing x-ray from the ground to your pelvis, just like when you walked in the door, because that's the most accurate. So some patients are able to stay a week, or they come back in a few weeks, or they send me an x-ray, whatever, because I just like having the truth is that final x-ray. But that's a way we tell. Or I'll say to somebody, you are getting tight, you are safe to continue lengthening, but your final x-ray is going to be compromised. And I have a measurement error of a 0.5 centimeter, whatever it is, I'm making up a number. And until you can stand with your feet on the ground and your knees locked and your hips straight, that's the best I can do. You can stop now and it'll be more accurate, or you can choose to do more, but understand you may have a difference of 5 millimeters, 6 millimeters is totally normal. And most people choose to do the last little bit of lengthening. And then we talk about strategies if they can come back in a week or two, because you can always compress a couple millimeters a week or two after you finish. But if somebody's tight, I will never add length to make up a difference, especially if you've gone to 80, you can't add any more length. So if there's for whatever reason, someone has an issue with their ERC or they're marked in the wrong place and they have a 1 centimeter difference and they're getting ready to leave, we're going to compress the long side half of that difference, 5 millimeters or so. And you can do that in clinic in 10 minutes, take an x-ray and prove it worked. So so I'm sad this guy had it. So what options exist for someone who has a lengthening nail and the leg is short? You can re-break the bone, take advantage of the nail if it still has length in there, and you could finish up your lengthening.
Yeah, I think that he got it done with the LON because, he had insurance in Thailand and then with the trauma nail in there. So I think he'll have to kind of do, but yeah, no, that's great. I think that he's already in contact with you. So I'm glad he'll follow up. All right. So this next question, let me stop sharing that. Okay. So here's the questions in the chat. So Voss is actually talking about putting feet flat down. He says, I'm 45 days into my lengthening. Right now I have a hard time walking flat footed and my knees are bent. Do my nerves stretch back to normal when I'm done lengthening? Do they go back to normal?
So first of all, I hope he's lengthening his tibias.
Yeah, that is a good question.
You know that? If your ankles are tight and your knees are tight, you need to stop lengthening now. Eventually things will stretch back, but how much is too much? If you're tight in 2 joints and you're still lengthening, shame on your surgeon, shame on your therapist, shame on you, but you don't know better. So I'm telling you, if you were my patient, I would stop you. Now, I'd stop you, we'd double down on your therapy, you'd do more, we'd make sure you're wearing your splints right. If you have therapy in a package, I'd say start doing 2 a days, and I'd reassess you in a couple days. And if you're getting looser, we could always resume lengthening. It's very rare the tibia is going to seize up, even if you stop for a week. So here's an example where we may slow down or stop lengthening, not for pain, but for contracture. We will never guarantee length. We'll guarantee lengthening you as safe as possible. And I don't care if you're at 2.5 centimeters or at 4.2. If you come to me with tight ankle, tight knee, your lengthening is done today. Maybe you can resume, but prove to me you're worthy of resuming, because you may not recover from this without soft tissue release, and then you get weakness. And who even knows what this guy's bone looks like? If they're lengthening through contractures, I'm guessing they're lengthening through non-unions too, but that's a big assumption on my part. But I would like to see x-rays, and it's baffling to me when we get messages like this.
Absolutely. I mean, because a lot of patients are doing quadrilateral lengthening at both
Yep.
limbs at the same time, and they get
Yep.
contractures at 2 different joints, so
Yep. Yep.
it's very
Yep.
possible.
Yep.
Animal Trends is saying, can you walk us through the 3 days in the
Yep.
hospital, what that looks like after surgery?
Yep. So you wake up after surgery, and at some point our goal is to get you upright. Now, if it's a weight-bearing nail, you'll be able to put full weight on each leg, but you won't be able to do that unassisted. So when you're in the hospital, regardless of the nail, a current nail, a nail on hold, or a past nail, you will need to stand with assistance. And I don't mean just using a walker. I mean people actually physically supporting you, because your muscles are all going to be inhibited. You're going to be sore. Your balance is going to be off. Your blood pressure is going to go down. You're dehydrated. You're hungry. You're uncomfortable. So the therapist will literally come to your bed and say, we're going to teach you how to sit up. And you're going to be like, sit up? I've been sitting up since I'm 6 months old. Okay, slow down. They're going to teach you how to sit. And then they're going to get your bearings. And they're going to teach you how to stand. And you're going to get your bearings. And they're going to teach you how to use a walker or some other assistive device. Even if you have a weight-bearing nail, you're going to use an assistive device for several weeks at least. And they're going to teach you how to walk. So every day, first you sit, then you stand, then you walk, and they work on all of those. They'll show you how to manipulate yourself in bed, to roll on your side, to push up with your hands, how to transfer to the bedside commode or to the wheelchair. So it's literally babying you so you can move around. And the goal to leave the hospital is you have to be independent to care for yourself. You have to be able to get to the bathroom. That's a critical thing. And your pain has to be controlled. So we use powerful medications. One of them is called Toradol, which is an anti-inflammatory. That's an IV medication. And then we use narcotics as needed. Some people need narcotics, some people don't. We supplement with Tylenol as well. And after the pain is under control, your mobilization is good, then you go home and you start recovering from wherever you're staying. That answer your question?
Yeah, it does. I mean,
a critical thing is, and now let's talk about your risk mitigation. So we're going to start you on a blood thinner the day after surgery. If it's a full weight bearing nail, we'll start you on aspirin. If it's not a full weight bearing nail, you'll be on a prescription medication called Xarelto, which is a very safe blood thinner. Note to Paley Institute patients, it's not covered by insurance and it's really expensive. It's like $600-700 a month. And you're going to be on that for lengthening plus consolidation. So if you're not a full weight bearing nail, 5 to 6 months you're paying for this expensive medication. But the cost of the medication far outweighs the risk and potential complications from a blood clot or a pulmonary embolism. Doesn't mean they can't happen, but our rate is incredibly low using this very safe medication. And the first couple hours after surgery, you're in the post-operative care unit where we're closely monitoring your blood oxygenation to see how your lungs are doing and how your body's tolerating the surgery. Fat embolism, the specter of this fat embolism and fat embolism syndrome exists in the first few hours, 10, 12 hours or so after surgery. So we're monitoring you closely to make sure your lungs are doing okay. And our 2 cases of fat embolism were happening in the first few hours after the patients woke up. There hasn't been a one like it. If you make it to nighttime and all is well, then you're not going to get that. You can get other things, but you're not going to get that. And that's the real dangerous scare. And then that's your hospital stay.
Yeah, that's awesome. No, that's super in depth. That's like, I'm gonna have to like put that into like a video right there. That's super powerful. Timeline. Yeah, timeline. Like that's what happens during surgery. All right. So Angelique stands. So this one, he's saying, he actually asked a question about bowed legs. So bowed femurs. I think you answered this before in a previous live, but he's saying if you have bowed femurs, can you straighten it out during the lengthening of the femur?
So most people, the femur is straight. Even if your knees are knock-kneed or bow-legged, the femur itself is straight, and typically the bowing is in the tibia. All femurs from the side view have a bow. And if I put a straight nail into a crooked bone, it straightens it out some. Some people it straightens out more than the other. It depends on how much bend you have to start with. It depends on how long the nail is. It depends on how big the nail is. It depends on how much room there is inside of your bones. So the sagittal bow, the bow from front to back that you don't see with your eyes and you don't see on a front standing x-ray, that bow does straighten out a little bit. If you have an actual bow in your femur from the front view and you put a straight nail in, that's going to straighten out some of that bow. But that's not very common at all.
Gotcha. All right. He's asking about weight loss. I think we actually talked about metabolism in the last one, so I'm going to Has to be
Yeah,
that one.
it's
Yeah, that should be.
calories, metabolic demand. It's fewer calories coming in because it's harder to snack when you have to get up, use a walker, and go get food. So it's fewer calories coming in, and then it's your body burning more calories. So it's a double whammy. It's the increased metabolic demand, and it's most people have fewer calories coming in after surgery, which is not good. We want you to be in a catabolic state. Anabolic state. We want you to be taking in more calories because you're burning a lot of calories to grow tissue.
Right. And you even said it last time that you're losing muscle, so that's why people lose weight too, like atrophy.
Right.
Yep.
Yeah. Right.
Yep. Okay.
I lost 4 pounds on my run last night. That just sweating. It is water weight. It was all back in the morning, unfortunately.
That's how you can do it. That's how you can make weight if you have like a sporting event. Just run 12.5 miles.
Well, when I go to my dietitian in next month and I have my blood work again, heck yeah, I'm going to run and not rehydrate before I go weigh in. Yeah, I'm going to game the system, man.
That's awesome. All right. David Reamer says, would you recommend a quadrilateral surgery for if he wants 9 centimeters, 5.5 in the femur, 3.5 in the tibia? Could I still run and function normally if I go for conservative lengthening like this?
Yeah, I'd even do 5 and 4, 5.5, 3.5, whatever. Yeah, your ratios are going to stay pretty darn normal, which, by the way, even if your ratios are different, you're still running and jumping and functioning normally if you just do femurs or tibias. But yeah, quadrilateral for 9 is very realistic. No guarantee. We've had a couple people lately who barely got to 8 doing quadrilateral. I just had someone who got a little over 11 quadrilateral. So he raises the average, which is great. So yes, I think that's a wonderful plan, all things being equal. But if you're going to do 9, why not just do 8 in the femurs? It's half the risk, it's half the cost, it's quicker recovery, it's fewer potential problems because it's 2 bones instead of 6. So there's always that to consider.
That is true. That is true.
Everybody has a plan on paper. Wait till we do your tibias, and then you're going to go, holy crap, I'm coming back to do my femurs in 3 weeks? What in the hell was I thinking? And that's a really real thing to consider. Do 7 in the femurs. Call it a day if you're worried about the aesthetics. Do 6 in the femurs. You're going to be so thrilled with one surgery. You're going to super recover. And if you want more length, fine. Next year, come back and do your tibias. It's going to cost you the same. The difference is it's 2 stays in Florida, which is some cost. But if you're going to do 9, do 7 in your femurs and call it a day. And again, this is what I do for a living. I got kids to pay for college and stuff. I'm not trying to talk you out of surgery, but it's easy to write down on paper what you want, but there are real risks and complications. And quadrilateral is twice the risk.
That makes sense. Absolutely. And you're pulling the tissue from 2 different points all at once. I do think though, I like this conservative femur of 6 centimeters. That was in one of my videos way back. I think that, it keeps you, it doesn't mess with your proportions too much. Your biomechanics are relatively maintained. You can relearn and readapt. And I think that a lot of patients recover really well at like capping at 6, maybe less, but I think 6.
But 5.5, 5.5 may be tough. Where this is a nice recipe though is if you're doing 3.5 in the tibias, you're going to finish your tibias. Probably, we could do the math, but probably 3 to 4 weeks before you finish your femur. So if you're starting to get tight, by the time your femurs are done, your knees are going to be a little looser and your ankles are going to be a little looser. So I like this better than 5 and 4 because you have more time to get your ankles back stretched out before you return home. So that's great.
And when you say that in an ideal world, let's say that less the complications and risks that having a better biomechanics for like squatting, like if this person wanted to squat.
Yes, you're right. So 5.5, 3.5 changes your biomechanical ratio is slightly less. But again, people are squatting. The difference is it is harder to stand if your knees stick out 2 more inches than your tibias. Your center of gravity, you must lean forward more. And if you're a deep squatter, you maybe become a front squatter, or you're just not deep squatting anymore, which has its whole host of issues. But from a biomechanical point of view, if that is an important number to you, and to us it's kind of just a number, then yes, doing quadrilateral will keep your ratios more aesthetically pleasing, possibly, but definitely biomechanically. So doing the quadrilateral for 8 to 9 centimeters, I think is conservative and realistic.
Okay. All right. And then he's asking if he were to do that, how far would he need a space lengthening? Would he get a second nail? So 3 weeks, obviously you said you do the tibias first, then the femurs.
Tibias first and then femurs. Or you could do femurs, and then depending on how much length you get, what nails you have, and how quickly you recover, you could theoretically do the tibias 8 months later, 7 months later. If you did 5 in the femurs, you probably would be recovered adequately that you could do the tibias maybe 7 to 8 months later, all things being equal. We generally just say a year, do femurs, and then a year later do tibias, or vice versa. But that number has some fluidity to it.
Okay, very cool. All right, and then he has one more question before we move to the next one. He's saying, how are the precise max patients that you did doing? Are they walking normally?
Patients, not the nails. I don't know about the yeah.
Yeah. Like,
so a lot of them walk without a walker after a short period of time in the house. I want all of them to use something in my clinic and out of the house for safety, for balance. Babe, I walked him before I left. I walked him before, no, not now, at like 4. And he did a giant Marshall poo, and she didn't want to get up. But I'm sure he'll want to walk again. Holly's walking kisses right now. Okay, so sorry about that. So the max patients who have the full weight bearing nail are allowed to stand unassisted. They're walking unassisted short distances and around the house where they can stop, rest, hold on for balance. But even if you have a weight bearing nail that far exceeds, you have a 13 millimeter nail for 250 pounds and you weigh 150 pounds. And we have 2 patients like that. One was 78, one was 79, or 79 and 80, by the way. And it was unilateral, not for stature. I wanted them to use assisted device just for balance and safety. How to walk normally, none of them are far enough out yet. Our first ones, it's probably coming up pretty soon. I think our first ones went in, God, is it already a year now? Was it November?
I think they had it in February. That's what.
Okay, so maybe it was February. So we have people now who I've given them, your bone is healed, you can do anything you want. Now, to reiterate, regardless of the nail type, max or precise 2 or stride or whatever it was in the day, bone healing and soft tissue recovery are different things. Bone healing is important to advance your weight bearing, either to ability to walk unassisted without fear of collapse or nail or bone breaking. But soft tissue recovery is often what's still limiting you. So if you have a max nail and your bone is healed 2 months after you finish, you're not running, and it's not because your bone isn't healed, it's because your tissues are still tight. The benefit of the weight-bearing nail is you're keeping your walking muscles and your core muscles and your stabilizing muscles a little more in use than if you have a precise 2 partial weight-bearing just because you're allowed to walk and stand. So in theory, there will be a quicker return to function, but I don't see you again after you leave until I take the rod out, and by that time you're recovered. So whether it was 6 months or 12 months, I don't know. It all kind of gets mushed into that void between visits with me. So with a full weight bearing nail, if you are able to control your muscles and your balance is good, you can walk without a walker in a safe environment around the house, short distances. But please use something outside of that safe environment, like in the community.
Right. Makes sense. All right.
Did I tell you my ring running issue?
No.
Oh my gosh. So since we're going so fast, so I run at night. Just running at night. The sun's not up. Watching me run is not a pretty sight. No one needs to see what I'm doing. It's like when I used to do P90X. There's no mirrors around. I know what I look like. So I run at night. I run alone. I don't run with people. So I'm running, and most people have a thing with spiders. Like around my house now, there's spiders everywhere. But in the oak trees in my neighborhood, there are spider webs that often are across the sidewalk. I mean, if it wasn't there last night, it'll be there tonight. So Holly and I are constantly looking for spiders so we don't walk into them, but we always hit a spider web. So this is like 3 weeks ago. I'm doing an awesome run, and I've been losing weight, and my ring is getting loose. Plus, I'm sweating a lot because it's 90 degrees in humidity. And usually, I'll take my ring off and tie it to my waistband or just leave it. But I'm running, and I'm thinking about my ring. And as I'm running, I see this thing suspended. As I'm running to it, my brain is saying, that's a spider. And now I've passed the point of where the suspended thing is, and now I feel the web. And I'm like, wait, what am I doing? So instead of backing out of the web, I rotate. So now I've wrapped myself in the web, and there's giant spiders on my arm, and I shriek like a little whatever, and I go like this, and my ring goes flying off and goes click, 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 down the sidewalk at 10 o'clock at night, 5 miles from home, and I'm like this, and the spiders, whatever. Yeah, so that ring is gone. But I always have a backup. These are little rubber gasket rings that I have on my keychain. So my it's a $19 steel band from Amazon. I should have bought 2 when I bought the first one. So my replacement is coming. But I look at this and it makes me think of it's not arachnophobia. It's me just being an idiot.
Wait, so that was your real ring that actually
That was my real ring, yeah. My real ring went clink, clink, clink down the sidewalk.
He learned his lesson now. Oh, man. And you told me when we were texting the other day, you said that you lost 30 pounds since March or something?
I've lost since March. I was the heaviest I've ever been. I was over 200 pounds. I carry weight very well, but I'm only 5'9", 5'10". It's a lot. I was full in the middle. But yeah, I'm down, well, after my run, 30-something pounds.
That's incredible.
But I feel better. My clothes fit better. I just feel better. I'm sleeping better. I'm back in the gym. Like, yeah, it's good. But it's a pound a week. You lose weight in the kitchen. You don't lose weight in the gym. And you know this. It's all diet. I cut carbs out, and this isn't pro or con going into ketosis, but it's like that question about weight loss for the other guy. If you take fewer calories in, by and large, all things being equal, if you take fewer calories in, you're going to lose weight. A couple pieces of bread, a couple cookies, a Coke, an apple. 150, 200 calories here and there adds up, and a pound a week over 5 months is 30 pounds. So
that's incredible.
So,
I told him. I said that he can technically do a contest diet with me because I lose anywhere from 30 to 35 pounds for my diets. He pretty much did it. I mean, this is incredible. You look like a different person. Incredible. Wow.
My clothes fit. It's so good. What prompted it was we had a wedding in Italy 2 months ago, and in March I couldn't wear my suit. Like I couldn't actually, like, you got the tight suit that you suck it up and you pull the belt tight. I couldn't button my pants. I was sitting on the couch with my buddy, and I was like, dude, you put on some weight. He's like, dude, you put on some weight. So we both were like, that's it, we're going keto. So I did and stuck with it, and he didn't, and he gained weight, and he's now heavier, and I'm 30 pounds lighter. So,
he probably hates your guts. He's like, oh, you suck, Greg, you suck.
Look, so I'm living proof. You gain weight slowly and you lose weight slower.
Yep.
It is very disheartening. And I'm afraid of the scale. I stood on the scale for the first time consciously a couple of days ago because my dietitian said, Craig, you have to have a healthy relationship with the scale. It's like, I don't want to step on the scale. And she said, you didn't step on the scale and you gained 30 pounds in 10 years. If you step on the scale on an interval, you know what your weight is and you can make adjustments. And she's not into austerity, and she doesn't think ketosis is for life. But got to have a healthy relationship with food. But I'm on my journey. My ketosis, eating bacon and ribeyes, made my lipids terrible. So my diet is a work in progress. But I'm very conscious of what I eat. I'm also 53. I'm not 28 anymore. You can eat bacon all day long when you're 40, and it doesn't do anything. I'm not 40 anymore. So things are different. But yeah, 30 pounds.
I can't believe that. I mean, and honestly, just the diet changes alone, that helps your health right there. I mean, it lowers the risk of diabetes. I mean, and everything like that. So good job, Dr. Robbins. Keep it up. It's incredible. Exactly. You're motivating me for the start of my diet in early December. So I'll take that and go forward with the torch.
My daughter's in Louisiana, so it's an hour earlier. So I finished my run at like 12 o'clock or 12:30 last night. So I called her and said, hey, guess what? I just ran 2.5 hours. And she's like, oh my gosh. So this morning she woke up and she ran a super fast pace for 4 miles. She's like, you inspired me, and she inspired me, and just,
Is that Elle?
Yeah, that's Elle.
Yeah. I met her when I was down there. That's awesome. Very cool. Very cool. All righty. Okay, so picking back up here, guys, from Edwin Louisa, he's saying, hi, Vic and Dr. Robbins. Is it practically possible to have quadrilateral lengthening of 5 centimeters each, and 3 months after consolidation, just have femoral 5 centimeters?
Maybe do tibias for 5, and then 3 months later do femurs for 5.
Maybe that's what I mean.
Yeah, because we say doing it 3 weeks apart, you can go for 5 and 5. So you could certainly do it 3 months later, and you probably have a better chance of getting 5 in the femur. You have a better chance of getting 5 individually, doing them 3 months apart, than you do doing them 3 weeks apart, all things being equal, because it's only one at a time. And there's just something to be said. It is definitely more than twice as hard to do 2 of them simultaneously, because that poor little nerve is getting stretched at both ends. And it fights back, and your knee gets tight, and your ankles get tight, and your hips get tight, and you get cranky, and it's a lot of work. It's a lot of work to do one lengthening. Imagine having to do 2 lengthenings. So I'm a big proponent of unilateral. Yes, it is practically possible to do tibias, and then 3 months after consolidation, do your femurs for 5 centimeters each. That is definitely doable.
Okay, very cool. All right, so we have about 3 more questions in there, but before we finish out those, I want to go ahead and bring on. We have two guests backstage, so we're going to do a little bit of live paneling here. We have Raphael, and then we have the Master Distractor, who was backstage earlier. So Raphael, welcome to the show. You are on the show with Dr. Robbins. Raphael? Okay, he kicked off. We have Socrates. Welcome, Socrates. Anybody? Master Distractor?
Yeah. Can you hear me?
Yeah, we hear you.
Okay, Master Distractor, you're on.
Go, Socrates.
Okay, great. Thank you for having me on. Super big fan, and thank you for everything you guys do. And also, I also lost about over 40 pounds this year, and did the exact same. Just trying to get in weight shape for increase my cardio and reduce weight for the nails and stuff. But yeah, I had a 2.5 hour run too, and I think a couple of days ago. But yeah.
You probably ran further than I did.
Sorry?
It's okay. Not a pissing contest. We're both out there doing it. That's what matters.
Yeah, I know. No, I mean, I don't know. I'm trying to do it more, but I think I'm good now. So yeah, I think for questions, I was just trying to make notes while you guys are doing it. For vaping, how far away should somebody stop before for vaping or nicotine, or any nicotine? How far away should somebody stop? As far as I heard, I think it's like 3 months, but I'm not completely sure.
Vaping today, right now, throw it away, never vape again. That has nothing to do with that is just vaping is idiotic. There's a lot of things that are idiocy, but vaping is probably the biggest because nobody knows. It is so bad on so many levels. So stop vaping today. Nicotine smoking, stop today for the same reasons, but less emphatically. The longer you stop, I've never smoked. I told the story of my aunt who was a child of the 60s. Heroin and cocaine, no problem. Nicotine, kicked her ass. It was hard for her to quit for many reasons. It's psychological, it's socially acceptable, although it is less now than it was. But just smoking was a thing. You could smoke anywhere back in the day. So smoking's hard to do. So to think you're going to quit after 10 years and then have surgery a week later and then be stressed out, not sleeping, having discomfort that you're not going to reach for a pack of cigarettes is silly. So quit today. Have surgery in a year, everything's fine. How long do you need nicotine out of your system so it doesn't affect you? Probably a month. Whatever that period of time is, it's not getting the nicotine out of your system to make your surgery safe. It's getting the nicotine out of your system so you don't relapse. Because if you then take nicotine back into your system, you're running the risk of delayed healing, wound complications, etc. So stop smoking today. Have your surgery whenever you want. And save that $5 a week. I don't even know what cigarettes cost. Whatever. It's like fine. So I don't drink coffee, so I don't do Starbucks. Polly and I don't know if you can see it right there. That espresso machine was super expensive. That thing is paid for itself 10 times over because we make espresso every day for Holly. So save your $5 in cigarettes or 10 or whatever.
I don't think it's $5.
And buy more therapy.
So I mean,
so quit smoking.
I stopped like over 2 years ago. So I just wanted to know.
You're more than fine. Yeah, there are no residuals that long out.
Okay. And I mean, I think the other thing is just for stretching for prehab. So I'm usually like stretching in like an hour, but I'm not making that much progress in my opinion. Like, is it better to stretch like several times a day, or what would be like a better stretching?
You're not going to be so much looser. Your surgery is not going to be any easier if you're prehabbing. You're prehabbing so that you're less sore. But remember, you can't do distraction rehab on your own. You can do some of it, but you need another person, whether it's a paleo therapist or your mom, your dad, your boyfriend, girlfriend, whatever. You need another human body to help you maximize your stretching. So there's only so much you can do on your own anyway. But there's 1,000 ways you can stretch when you're not post-op. You have no restrictions in lever arms, positioning. You could watch 50 different yoga videos and try all of them and find what works for you. Just because you're stretching doesn't mean you're stretching correctly or you're doing the right things.
Yin yoga.
Yin yoga. Holly
Go
says,
on YouTube.
YouTube, yin yoga.
Like Travis Elliott, hip and hamstring.
There you go. Travis Elliott, hip and hamstring. That's for prehab. That's not for
Prehab.
post-op. Yeah.
Prehab.
Okay, there you go. Travis Elliott, yin yoga. Says Holly.
Yeah, I was looking at Kathy Medeo yoga, but it's very hard.
Oh yeah, any
Or
yin,
Kathy.
just
Yeah.
put the yin.
She says yes.
Okay.
She says yes on the yin.
Okay.
It's Holly approved.
I mean, it's so. I was trying to do the splits, but I mean, it's so difficult trying to figure out how to do it. But so yeah.
The fact that
thinking
you're
about-
thinking about it and you're doing something is good. You're going to be going into the process. And we were talking offline. You've been thinking about this for a long, long time. So the chance of you not being successful is less than someone who just found out about this and threw themselves into it, not fully being invested in it because they haven't thought about it for long enough. So you're doing all the right things. I think you're well on your way to having success wherever you are. And even if you're not with us, you're armed with the right knowledge and questions to have conversations with your surgeon about your recovery and your follow-up and what you need to be doing. And you know what the warning signs are if there's nobody watching you as closely as we do at the Paley Institute. So I hope you come to us, but if you don't, at least, again, that's the whole part of what Victor's doing here is getting information out for the patients, because not everyone's going to come to us, and that's fine. We want you to be the most educated you can be so you can have good dialogue with your treating team wherever you are. So good for you. You're doing everything right.
Thank you. Should I keep going with my questions or let other people talk?
Yeah, I was going to bring in some more questions from the chat and just kind of mix it up a little bit, but you can ask another one. Go ahead if you want. Yeah.
I don't know if this is gonna make any controversy, but can we? Is it possible to get an opinion on like the G nails and the Betz mode and the Albisa nails?
I've never used them. I can't tell you a thing about them. I've never used them.
Okay.
I do have a video on them, and I know they're mechanical nails, and I put my opinion out there. I will say, and this is my opinion, I think that there's a learning curve to learning how to distract with those, and some patients have told me that it's very painful. But if you learn how to do it, you know, that's up to you. But yeah, to watch the video.
I watched that ones too.
Okay.
I watched all your videos.
The best implant is the one your surgeon is the most comfortable using.
Right.
So I have no experience with the Betz nail, so I may be a great surgeon with Precise, but my learning curve for Betz, it would probably be faster because I have experience with other things and not everything is totally new invention. But whatever the experience is with your surgeon, they can tell you, I put in 10,000 of these or 2,000 of these, and this is the general consensus, and they should be able to tell you about their own patients and their results. If not, then maybe look elsewhere. But we did this with the Lizaroff. We did this lengthening over nail. We did this with monolaterals. We did this with hexapods. So everything's a learning curve. And there's not to say new surgeons can't do a good job. But I'll say it again, we don't earn our money in the operating room. We earn our money in the post-operative management and preventing complications that you don't even know we're doing. You don't want to know what the pilot's doing up there in the cabin. You just want a smooth flight and take off and land. All the things they have to go through is for them to know. We spend most of our time preventing problems that you know what the problems are because you're on this forum and you see the disasters that can happen. And not to say we can't have disasters too, but hopefully we recognize them earlier so they don't progress and we can keep you from the point of no return or from unplanned surgery. So keep arming yourself with knowledge and education and you have good conversations with your surgeon.
Okay.
Real quick off of that, I know you just said externals. We have Kilo Khan. He's a longtime guy from the forum from way back when I first started this. He had a question. He says, do you personally prefer the lengthening over nail or LATN lengthening and then nailing for tibial nailing in a scenario where the fully internal, like precise nail is not available for that patient?
Tibial fixators are so well tolerated. Just leave the fixators on and then don't worry about it. Why have extra surgery? have one, do your surgery, do your lengthening, take it off when you're done. Easy for me to say I haven't had one or two, but why? I mean,
Yeah.
What's the difference? Lengthening over a nail or lengthening and then nailing? It's the same concept. The concept is you're getting the fixator off earlier and you're putting in a nail, whether you put in the nail on the front end or the back end. I don't have much experience. I have it in unilateral and trauma reconstructing, but I don't have any experience doing it for stature. But if internal lengthening nail, just do the fixators and leave them on until you're done.
Okay, very cool. Alrighty. And then Socrates, welcome. How are you?
I'm doing good. Good to see you all.
Good.
How are you?
Did you hear Dr. Robbins just ran 12.5 miles last night?
Yeah, I was listening as I finished up some work and then I joined. So
Isn't that
good
crazy?
job. I will have to schedule my next follow up with my primary care physician like the day of my marathon.
Yeah.
my next marathon.
Because are you planning to do one in January?
No, it's not realistic to do that. May 3rd is my next marathon, and then in September for my next birthday, I'm either going to go to Berlin if we get selected or Alaska.
Wow,
Cool.
that's crazy.
Yeah, the
That's
Anchorage
good
one
times.
is on my list. Yeah, I don't know if I want to get back to marathon distance. We'll see. I mean, if I can run 12, I can run 20. If I can run 20, I can run 26 because I've done it. It's just,
Exactly.
a
A marathon is 2 10-milers and a 10K, or it's 2 half
It's a lot.
marathons, or it's a bunch of
it's
5Ks. So it's just one run after the next.
A marathon is more than twice as hard as 2 half marathons. Let's be very clear. The second one's harder than the first.
That
Definitely
could not be
diminished.
truer. 100%.
Yeah.
But the group of friends that I was training with before my surgery, they just asked me, "Do you want to go to Berlin next year?" And I was like, "Sure, who doesn't?" And they're like, "All right, sign up. We're going to run a marathon." I was like, "Oh, you got me." The old bait and switch.
That's great. Which just proves the point, and we've spoken about this, that is headspace. Once you know your body can do it, it's just turning off the negativity and just pushing through. And that's what you do.
That's why, in my mind, I had to finish the marathon before I had this surgery.
Yeah.
And I remember Dr. Paley, I can't remember if it was Angelique or Lena who told him that I was planning on having my marathon on Sunday, the 10th of December.
Yeah.
And I was flirting with having surgery on the 12th, and he was like, "Let's push it 2 days."
You know what it feels like. I couldn't imagine having surgery tomorrow after my run, and that was a small run.
Yeah.
I'm sure I feel terrible. It's not a good idea. And
But
it's just, and
you
I'm
don't
sure
know what you don't know.
That's great.
In the heat of the moment, especially when you're getting into it, you kind of feel like you're invincible, and you're like, I had my first 20-mile run after my first half marathon, after my first 10-miler, and I was just like, the world is my oyster.
Yeah.
Let me break my legs the day after, and then that's why experienced surgeons are definitely important.
There's Marshall.
I do have 3 questions. The first one. So recently, some of the guys at the HP House here in Baltimore have been getting the meal prep from Factor or Cocoonity or what have you, and each one has their preference. What I've seen is that they tend to have fairly decent calories, but it's a lot of fat, right? So in your experience, Dr. Robbins, have you seen that the macro breakdown of the caloric intake matters much at all, as long as they're getting enough protein?
We don't track it, so I don't know. It's so varied. It's so varied for cultural, for financial, for age. Our patients are so varied in what they eat. We've never done a discussion or breakdown. I mean, we track weight, but there's so many variables for that. So no, that's why I say you got to have calories coming in. Healthy calories are better than unhealthy calories. But it is hard to get a lot of calories eating clean unless you're eating a lot of fat. And not all fats are created equal. Avocado is great. Coconut oil is debatable depending on who you talk to, but it's better than fried chicken. But if all you want to eat for a week is fried chicken, then eat fried chicken because you need calories coming in.
I remember the
nuggets every day, but
I remember in the first month, I was trying to get 3,000 calories a day, and I was tracking my calories fairly well.
Yeah.
But I was eating very clean because I had been dropping weight before surgery because I was fairly fluffy before I went on.
That's a lot of calories. 3K is a lot of calories.
I know. My habit, I had been eating 1,400 calories since September to bring my weight down to like 175. I got to 180, and then I was like, that's enough of that. So I would find myself getting like 2,200 clean calories, and then just like asking my mom or my sister, can you give me a Snickers bar or an ice cream or something? Like, I just need some fat. Right?
I'll show you what my guilty pleasure is.
It's gonna be like Snickers or something.
We'll see. It's not likely to be chicken and broccoli. That's for sure.
Too clean.
Oh goodness.
Skinny dipper, dark chocolate peanut butter cups.
Oh,
that's good.
This is, you know what? I ran last night. Watch this.
There you go.
That looks pretty healthy though. It's like a healthier,
there's no healthy. It's peanut butter and
healthier
chocolate.
version of a. It looks like a
Skinny
healthier
dipper?
version of a Reese cup.
It does. It does look like a healthy version of a Reese's cup.
Oh my God, I'm so good.
Oh, he's making us all so jealous. I'm hungry now.
I came home last night and I could not stop eating.
You probably went through like 13.
I don't blame you. No, those, any run beyond like 7 or 8 miles, like if you're running continuously for an hour plus, after that your brain's like, I need to spend as much time eating as I just spent running. Okay, give me. Your ghrelin levels are probably through the roof, and your leptin is probably just downplayed.
Do you caloric replete when you're running? Like, what's your distance where you'll bring a Cliff Bar or something? That was so good.
Generally speaking, I haven't, except in the sanctioned races, they'll give you like blue bars or bananas or whatever as you're running, or a Gatorade, like actual caloric Gatorade. So I'll ingest that throughout the run. But when I'm training, I don't. Like I did my 20-mile run, and I remember getting to 16 miles, and I was gassed, and so I found a 7-Eleven, and I grabbed a Gatorade, a 32-ounce Gatorade, but it was Gatorade Zero, and I drank it, and I finished the run no problem.
But you need salt.
We just have salt tablets. We just ingest the salt tablets before the run.
No.
Yeah, you really have to because it's dangerous. You know, a 2-hour run, you could probably get away with nothing. But if you're doing a long ride or along something where the heat is out there, you really can't forget about the salt, because you'll bomb hard and you cramp and it's terrible. But yeah, I used to have, I don't remember what my ratio was, like every 30 minutes on my bike, I do a salt tab. I'd eat a half a power bar, and you kind of count, because if you're on an 8-hour race, you can't bonk at hour 3. You just can't.
You hit the wall. And we've seen some people in the Alabama marathon that I ran were not able to finish because they didn't have the salt ingested. Yeah. And I distinctly remember one, he just kind of like, he lost his mind for a second. He was just running in circles, and then like people had to like let him down, and it's like your brain is just not functional because you don't have the salt. That was a scary sight to see, but we had a race and we finished, and we wished him the best of luck.
It's nice. It's nice. Supported races are nice because there's always something.
Yep. And in Alabama, the National Guard was monitoring it, so they had all the resources they needed to help him and anyone else.
Did we talk about, in past ones, we've talked about the book Three Body Problem, the Chinese science fiction by Cixin Liu that Netflix now has that serialization on. So in Three Body Problem, it's this future computer game. You put on the goggles and you put on the suit, and people interact in this virtual reality world, but everybody has the name of a philosopher. So every time Socrates comes up, I think of the game, because everybody, it's Socrates, it's Magellan, it's Einstein, it's whoever. It's just funny that's the name.
That's hilarious. So my second question is, I am trying to get back to proper running. The last run I had, I ran I jogged. I didn't really run, but I jogged a mile continuously in 17 minutes, which was a new record for me after surgery, but also heartbreaking given the fact that I ran a marathon less than a year ago. So it's kind of like a mind trip. And part of the reason why it was 17 minutes is that I had to go to the bathroom. And so I kind of had to cut through some uneven terrain. So as I was jogging on the terrain, I am fairly certain that I sprained, or at least like didn't particularly treat my right adductor as much as well as it would like. And then I proceeded to go to the gym with some friends the next day. And we have this really, really bad habit of, on the leg press, the safety lock mechanism. We bring it down as low as it'll go and force it to touch when we're doing the leg press. So I bent my knees as much as was required for that. And so I think I strained my hip flexors then, and it's just not recovered. So do I back off? I don't know what to do about it.
Most people, because I examine everybody before I take your hardware out, invariably, if you had femur lengthening and you come back a year later, you're back to most people are not getting back to marathon running. They're just back to normal. They can go to work, they can go up and down stairs, they can play a little basketball, but they're not good. They weren't good to start, and they're not good now. Okay. When I truly examine them, their tensors are very tight. Their rectus is very tight. Their psoas is even a little tight, even though that's not actually lengthened. And their IT band is tight. All of them are tight. And if you really watch them walk, they have a little bit of a shorter stride because they can't extend their hip. So the impediment to recovery, especially running, is definitely tightness in the hips. The rectus, the tensor, the iliotibial band, and the psoas. And you got to work all of those. And then for you also, because you have the lengthening, it's probably still abductor weakness. All of these things play a role. And then you're going off road, so your core is off, your stabilizers are off, and then you tweak yourself, and then you bottom down on the leg press. Yours is just idiocy.
I agree. I agree 100%.
No, you don't have to back off from doing your things. Maybe you need to stretch more and give yourself some grace.
Well, so on that note, I in physical therapy today, my physical therapist suggested that I massage more. I use the roller and whatnot. I have used it exactly zero. So in your experience, at this stage where I am, where I can walk, but I'm still waddling a little bit. I can't really run yet. Strength is recovering, but I still have some knee instability because the quad strength just isn't there yet. What would be a good ratio of strength training to stretching to massage?
I think treadmill running, there's something to be said for that, because you can get the cardio aspect by going a little bit on an incline. It's a little bit padded, it's a little bouncy, and you're not crossing over trees and stumps. And the bathroom is right next to it. So in all seriousness, you're less likely to run into problems getting your mileage up on the treadmill for a while. And that's not as much fun running on a treadmill. But it's
not fun at all. But
controlled. But you got to do 2 miles before you do 26. So
my goal is 3 miles by Christmas. 3 miles continuous by Christmas with no time limit.
But I think for you it's stretching and it's strengthening. But you do need some quad strengthening. But probably you're going to get as much. And Holly, jump in here. So he's post femur lengthening, trying to get back to running. He's post-femur lengthening. He's a marathoner before, trying to get back to running. He's bottoming out on a leg press. I'm going to say body weight stuff, Bosu ball stuff that engages your core, and that's not constrained is going to be better for him than doing like a leg press. So
leg press doesn't help you run.
Squats, split squats, single squats, pistol squats. What's it called when you hold the dumbbell here? And
I know what you're talking about, where you squat with the dumbbell. It starts with a G.
Goblet.
Yeah. You need 20 pounds kettlebell. You can work your legs like crazy with your body weight or a 20-pound kettlebell. You don't need to be bottoming out the leg press.
That was idiocy. That was 100% idiocy. So
that was idiocy. Yeah. I mean that.
My running group, they're just very happy that I'm back in the gym and I look not obviously injured anymore, so they just keep challenging me with things, and I need to learn how to say no.
So here's the question: when you're on the leg press machine, does it feel different than you because your ratios are off? Do you feel anything different?
It feels different.
Not
because
a strength thing, because that's
It's only strength matters. The ratio, the body mechanics on the leg press feel fine.
Yeah, there you go. That's
The body mechanics for squat also feel okay, but I'm doing squats to a box, and I'm not going ass to grass.
Gotcha.
I just don't have the balance
How
yet.
tall were you when you started?
I was 5'6", and I got 8 centimeters on the femur, so I'm 5'9" now.
You were 5'6". Okay, yeah, and that's the difference too, because your relative amount was less than if you were 5'1" when you started, or 5'2" when you started. So yeah, so there you go, folks. Now you heard it from an actual patient. Squatting not problematic, or leg press not problematic, but there are better ways to work the body than squatting, which we've been discussing.
Yeah, I'm planning on doing more single leg stuff.
Yeah, good. That'll be dividends because you're engaging everything.
All right.
Well, I realized one day when I was trying to do the hamstring curls, and I just did single legs. I did the leg extension single legs, and I can do roughly the same weight on each leg, but the right knee kind of bothers me because of instability that I've been experiencing. Yeah. So I'm not sure what the issue is there, because we did a quad strength test on both legs, and we're roughly the same strength.
But is that Biodex? That's a very constrained. That's testing you in a very constrained setting. It doesn't mean much. I mean, it's a baseline. It doesn't mean quite as much.
But the ratio of the strength between my legs was fairly close to 1-to-1. But the hamstrings, there was a significant difference.
Yeah, within the constraint,
it seems to be a lot weaker. My right seems to be a lot less stable, I should say. It's not necessarily weaker, because I can put as much force, almost as much force on my right with my hamstring as I can with my left. But if I try and do hamstring curls on the right side, I need a lot less weight.
Is she cutting out for you too?
It's a little choppy, but I can hear it okay. I think Dr. Robbins, it might be your bars that are dropping a little bit.
Yeah, everybody's.
They look okay now. They look okay now. Okay. All right. So, Socrates, real quick, I know that one thing that I've talked to a lot of femur patients as well from the recovery, they say that working the glutes, the posterior chain, is one major aspect. It stabilizes the hips and the pelvis. And obviously, me knowing a lot about that, but I think that, posterior chain, I noticed that helps tremendously for getting recovery back up to par. But okay, let's.
My last meeting with Moshe, he had me basically run up and down the stairs for an hour.
Did he really?
Yeah, basically.
That'll fry your glutes like nothing.
Oh, they were fried. I was going up and down the steps in various iterations for like an hour.
I would rather run 10 miles than walk 10 flights of stairs.
Oh, yeah.
The parking garage, I park on the 3rd floor at the gym. I'm winded walking 2 flights of stairs. It's just silly. It's crazy.
Oh, that's fun.
Elle just did 250 flights on the stair climber. She does an hour on the stair climber. It's like 4,000 steps. Yeah, she's a maniac.
What was her sport again? Wasn't it cheerleading?
Soccer.
Soccer.
No, soccer.
Yeah, she's a soccer player, so she's in the league.
Well, Holly and I just went out and watched her play a game. She had 2 goals. It was awesome.
That's awesome.
Okay.
All right, we're gonna run.
Okay, I guess we should get back.
Yeah, I know. They're like, come on, answer my question. All right.
Sorry, they're all waiting in the background.
Senor Duke is saying, I have femur surgery in January. When will I be able to get back in the office? So he doesn't have a physical role, but he does get back to company.
Yeah. So you have it in early January. So you're gonna have it in January. What's your time frame to be back in that? Well, it depends how much length you're doing. Depends on where you're doing it, because that gives me an idea of how much rehab you're having during your lengthening. It depends on how much rehab you're going to have when you return home. It depends on what nails you're having. So let's say it's the Paley Institute. You're doing 6.5 centimeters in January, and you're having precise nails. You can be back in the office the week after you get home, but you're going to be on a walker. You may be in a wheelchair just for distances because it's convenient. But you can sit in a chair and work. There's people who live in wheelchairs their whole life. So you could be back in the office as soon as you return home. But every hour you're sitting in a chair is an hour you're not stretching. Not to say you have to give up your work time to stretch 10 hours a day, but there is a trade-off. The more you can stretch, even after you finish lengthening and return home, the faster your recovery will be. But you can realistically be back in the office as soon as you return home, but you have to carve out time to stretch. Stretch in the office. You're the boss. Put a stretch table in your office. Okay, so a lot of people get irritation of nerves with lengthening, and it can be numbness, it can be tingling, it can be icy feeling or burny feeling, but we never tolerate weakness. If there's weakness, it's a hard stop and we assess. And that is so incredibly rare. That's like twice in 30 years for femur lengthening. Literally that rare for all things. I've very rarely, the numbness will turn to pain or discomfort. And if this is happening, I would now, if you were my patient, I would start you on gabapentin. We use it pretty liberally. It's very safe. It's very well tolerated. It won't take the nerve stretch away, but it'll take any of the pain or discomfort. 90+% of people, you'll stay on it for at least 2 weeks or so after you finish lengthening, and then you'll taper off of it. And the numb spot may persist for months and months, but we're trying to keep it from being painful. And I have one person now who's like a year and a half after, because I've taken the hardware out, and she has her residual numb spot. Now, I haven't taken a needle and poked it to see what does numb mean to her, but whatever numb means, it doesn't feel normal. If this is happening to you, I'll say to you, most people it goes away. Could you live with this forever? If you were taller for the rest of your life and this spot was numb, is that a fair trade-off? And if the answer is no, then we'll have a discussion about stopping. And if the answer is yes, then that may be one of the rare long-term sequelae is you have a little numb spot on your shin. It's very rarely truly numb. I think I talked about my wrist. I had surgery on my wrist, and I had a spot here the size of a quarter that I could put a needle in, and I didn't feel it for about a year and a half. And then now it's still slightly less, but a few things happen. One, the nerve recovers. Two, the outlying nerves grow into the area. And three, your brain starts to erase the defect. So if I probe this with a needle, the area is probably bigger than I think it is, but it doesn't bother me anymore because all those reasons. So I'm hopeful that will go away. I expect it to, at least to shrink rapidly, but I would probably consider starting gabapentin. You also want to look on your rate. You want to look on your flexibility. You really want to check your strength and make sure you're not having any weakness.
That's good. Good checkpoints. Yeah, shout out to the coach from Australia. He's one of the guys that came on the show before. Shout out to him. Naya saying, can the blood loss during surgery for the nail insertion be collected and processed into PRP to enhance healing?
No, because it's kind of insensible blood loss. It's not, for PRP, they take blood out of your vein. It's pure blood that's coming out of your vein. It's not mixed with bone marrow or, the grit of surgery. And it's not in one little area. It kind of disperses along your whole thigh. We don't have a lot of healing problems. And why do I want to stick a needle into my closed sterile surgical site? What if I don't clean the skin well enough? What if it's a bad needle? What if something was contaminated? I mean, those are very rare events, but we don't find that we're having healing problems. So we don't think it's not a problem that needs to be solved. Kind of like we talked about peptides before. Holly had peptides on her shoulder. I injected her for 40 days. Not much better at all. Our buddy ruptured his Achilles tendon and had a gap, a full inch gap by my exam. He did peptides and he is back doing CrossFit a year later. No surgery. He treated himself in a boot for like a month. And he is completely back to normal with no weakness. Crazy.
Jeez.
Yeah.
He probably knows where to get the good stuff.
Yeah.
All right. Next question. He's saying, what would be classified as disproportion? So if you're talking about proportions, is it the arm length, torso length, body length? What exactly, when you're doing the EOS scan?
Well, so how do you define proportion? Very likely, unless you have a known dwarfing type condition or trauma or growth arrest or chemotherapy as a child or something, you're a normally proportioned human being. You're just not as tall as you'd like to be. So your arm span is roughly your height. There are people like Michael Phelps, for example, who have, they call it an ape index. Your arms are significantly longer than your height, but it's a visual, it's an aesthetic thing. So if you start with normal proportions and you lengthen 1 millimeter, your proportions change. They don't change much, but they change. we don't lengthen by numbers. We lengthen by your aesthetics, and it's for you to decide what looks good for you. I put a lengthening nail in you, and I tell you, measure your height on the wall, pay attention to your vertical height. But you'll find very rapidly that the vertical number goes away after a few centimeters or an inch or two, and you get less excited that it's 2 inches or 3 inches. And I want you to look in the mirror every day and pay attention to your aesthetics and your visual proportions, how it looks to you. 95% of people, if they could go more, they'd go more. The aesthetics don't bother them one bit. But I don't want anyone to get to the end and say, wait a second, my femur looks longer than my tibia. Nobody told me this. Well, yes, I did tell you, and I remind you, because you need to pay attention to what looks good to you. You and 10 of your friends get a haircut or get jeans or get a tattoo. Don't do that. Or do whatever. You're all going to have a different variation or different thought on what looks good. So this is a very dynamic, active process. And everybody starts at 0 and lengthens a little bit every day. So you have lots of opportunity to assess how the aesthetics look for you. I'm not going to measure your arm height and your body height and say you should lengthen 5 centimeters, because that's not how it works. We will lengthen. Your body may not tolerate more than 5 centimeters, and so it's a moot point. I think you should do 7, but you can only get to 4.5 safely. Who cares if I think you can get to 7? That's part of the reason we don't. So we will help you do it safely, but you use your eyes and you decide what looks good, aesthetically pleasing to you, because at the end of the day, this is for you, not for me.
Right. And if you go too far, it's like you're too far. You're done lengthening your bone heels.
We all agree 15 centimeters in the femur is too much. We all agree 2 centimeters are probably not worth doing. So somewhere in between lies the truth. Well, our rod only goes to 8, so that's the most you're going to get in one back surgery.
Right. The mirror is your friend in this case. All right. DJ Cyborg for Dr. Robbins says, is venting performed for the tibias like you do for the femurs for lengthening?
No.
Yeah. Oh, no.
No, are very rare, but 2 cases of the fat embolism when the femurs, not in the tibias. Thank goodness we vent. I wonder if it would be more. Because why don't we vent? We don't want to drill holes through the back of the tibia, because the venting goes into the deep posterior compartment, which is much more constrained than the thigh muscles. And so the risk of compartment syndrome is real. So no, we do not vent. But we ream slowly. We use sharp reamers. When the bone is reaming, there's something we feel for and listen for called chatter, and it's giving us an indication of how the reamer is interfacing with the bone. So we'll adjust the rate that we're reaming. We'll stop and pause. We'll take the reamers out and clean them of debris. We'll cool them off with a towel. So there's lots of things we do along the way. We're not just jamming down like a carpenter, or we're bone carpenters, but we're paying attention to the biology. It's not just rote, stick a reamer and make a big hole. You have to do it thinking about it. So we do not vent the tibias directly, but we are reaming you safely.
That's interesting. Okay.
And it's not just for cosmetic lengthening surgery. We vent the femur for everything, not just cosmetic stature. Most of what I do is in cosmetic. So I'm venting more femurs for non-cosmetic, but all femurs are being vented.
Very cool. We actually just had somebody join. Kato was in the background here, but let's move on to the next one. So this one, actually, Master Distracted, did you have another question for Dr. Robbins while I find the next question?
Yeah, sure. I mean, I think you guys talked about like a osteome drill technique to break the bone. I'm wondering, and there's other way that was talked about with the saw. For the surgeons that are doing with the saw, I'm assuming he's shaking his head, so don't go to those surgeons.
Why would you use a saw? Big incision, clipping the tissues, heat generation. No, we proven a long time ago you won't need to use a saw to break a bone. Now, there may be reasons, but not for cosmetic stature lengthening. You're taking a wedge out, whatever the reasons are. No, for cosmetic stature lengthening in a normal bone, percutaneous osteotomy, preserve the soft tissue, preserve the periosteum as much as you can. Minimal heat generation. Yeah, don't use a saw.
All right.
We use a saw. Let me clarify that. We use a saw when we're cutting the fibula on quadrilaterals because we're doing a perineal nerve decompression. Perineal nerve decompression is an incision over the head of the fibula on the side of the knee, where we're prophylactically taking pressure off the perineal nerve because we're lengthening above the knee and below the knee, and that nerve's going to get stretched the most. The nerve runs directly over the fibula, so we are visualizing we therefore visualize the fibula through the same field. The fibula is on the sides of your pinky. So we will use irrigation and use the saw to start the cut, and then we'll complete it with an osteotome. So that's a little tiny bone. So that's the one instance where we use a saw if we're doing perineal nerve repair.
Alrighty, we have
Dr. Robbins. I remember I got a question on Discord, and they were asking what you might think the pros and cons of lengthening with TSF are.
Oh,
and if it's done for cosmetic lengthening.
Tons of pros. You can make it perfect. If you're getting valgus, if you're getting trocar bottom, you can fix it. If you want to dial in a little bit of rotation, you can fix it. If you're a little bowed or a little knock-kneed, you can fix it. So I love Hexapod. I think it's great. You can walk on it immediately. It's infinitely variable. Yeah, I think everyone's heard me say, if I ever break my tibia, put a Hexapod on me. I don't want a nail. I don't want a plate for whatever reason. So
you think it's preferable to an internal nail?
What?
You think it's preferable to an internal nail?
Me, if I trip running, put a Hexapod on, spatial or whatever, or X, whatever. We'll space filler, a Hexapod, computer dependent fixator is what I want. Personally. Hexapods are great. They're wonderful.
Okay, good to know.
Would the in Paleo Institute, would you be able to choose the Hexapod for tibias if the patient wants to?
Yeah, so Jor and I have this discussion, and he is very knowledgeable and very smart, and he will probably, at the end of the discussion, you'll probably be doing internal if you have the discussion with him. Why should we do external? We did that for 60 years. This is the new technology. This is what we have, especially with the weight-bearing nail. It's a big difference with a weight-bearing nail versus not.
Yep.
The reality is, and just because you have a fixator doesn't mean you're going to get up and walk. Just because you have the max nail doesn't mean you're walking unassisted. So I'm making big assumptions that bilateral hexapod tibia fixators that people are going to be up walking, they're still going to need the walker, and they have the pins, and they have pin infections, and fixators not to be taken lightly. I'm just saying, you asked the question, what's the difference? They both achieve the same goal. They both get the length, but you have more postoperative variability and adjustability in the fixator because you have none with the nail. You do have options. So the ideal person would be someone who has a little bit of rotation and a little bit of varus. We can correct that acutely and then put the rod in for lengthening, but you can correct it gradually and make it perfect if you do the Hexapod. I have two patients who came to me in their 50s and were having knee pain. And will probably, at some point, they may get degeneration and get knee replacement. But we're trying to prevent that. So we used the fixator to correct their alignment. And while we were there, we added a half an inch or an inch of length too. But we could also dial in a couple degrees of rotation they liked. And I could dial in the alignment. I actually overcorrected just a little bit and made them very slightly knock-knee by 1 or 2 degrees. And that offloaded pressure on the inside of the knee where they were getting knee pain. That's a very specific circumstance. So in that scenario, I think the Hexapods were perfect for that patient because they're already having knee pain. So the primary thing wasn't length. It was realigning the knees. And the Hexapod lets you adjust it. So on the first side, we overcorrected 2 or 3 degrees, and he didn't like it. So we backed off a degree, and we quite literally dialed in his alignment where it felt perfect for him. And then we stopped, and then he healed, and it came off. And then we did his other leg. We did those one at a time by his preference, because his one knee hurt really bad, and the other one didn't.
That's incredible. Awesome. All right. So I got 2 more questions in here. So this question from Carlson is saying, I play hours of club volleyball, and it's a lot of jumping, powerful bursts, lateral movements, and he even dives into the court. Should I be worried about, the longer bones that he lengthens to break more easily?
Is this after lengthening? What are we talking about?
Yeah, once he's healed up after femur lengthening.
No, I mean, knock on wood, we haven't had anyone break after lengthening or after hardware removal. The expectation is full return. Now, if your hardware comes out, I'm probably going to keep you from doing that for 2 months while the bones heal. And we can have that discussion. Do they heal with fibrous tissue? Do they fully heal? And who knows? But I've not yet had anyone break, fracture after removal that I can think of. But I will restrict you from those type of movements for 1 to 2 months, depending on your age, where the screw holes are, what your bone looks like, etc. So, but the expectation is you'll get fully back. But how many people doing that break a leg who have never had surgery? The answer is not zero. So just your sport itself has some inherent risk relative to walking.
So Nyanad's really worried about the blood loss. So they're just saying, do you have a rough estimate of how much blood loss is there? And should they have any concern, stem cell loss, bone marrow, and all that?
Yeah. Another way of asking that is how many people need a transfusion? And after single lengthening, either femurs or tibias, our blood transfusion rate is so incredibly low, less than 1 or 2%. Now, if you're a very tiny person and you have tibias and then 3 weeks later have femurs, that's probably the most common, and that's still a very low rate. Now, if you're worried about it, then before surgery, take your vitamins. Make sure you're taking iron or eating red meat. Hydrate. Do good nutrition, and boost yourself.
Got it. Let's see. Where can I post my questions? In the chat here. I'm trying to see. Did you post the question? I might have missed it. Let's just answer this one really quick.
You posted your question.
Yeah, I'll go back and find it. But this question here from Fernando, while I'm looking for that one, should I stay in the U.S. for at least 1 year, or can I go back to my country after the 3 months of lengthening? How much time do I need to remove the nails?
Most people go back, they finish lengthening, they see me on a day, and a couple of days later or the next day, they fly home to their country to recover. They send me x-rays every month to assess for bone healing. And the nail generally is coming out a year after your surgery or a year after you finish. Your bone has to be fully healed enough for nail removal, which is different than being healed enough for running and jumping. And you have to feel like you've recovered. So usually it's a year after surgery or after healing, sometime in that time period, 12 to 18 months after surgery.
Okay, I found his question. All right, 12 to 18 months. So funny job. This is a question. I went back up and found it. I'm 21, standing at 5'8". Would you recommend femurs can be done safely
Always
on Canada?
Always femurs is my recommendation, unless there's a reason that it is.
Right.
Yeah, femurs. Yeah, do femurs. Especially you're starting relatively tall relative to most patients doing stature lengthening.
Right.
Yeah.
So femurs first. Go for the femurs. Yeah. So I think you have to answer in one big paragraph for a specific question. Okay, cool. I think that's all we have in here. So, Master Distract, do you have any last questions, or Socrates for Dr. Robbins? I think that we're good.
Yeah, as we're talking, one of my buddies who's an ENT, his son fell off the monkey bars and probably has an elbow fracture. So he's coming over and I'm going to put a cast on him soon.
Oh, really? That's so crazy cool.
Yeah.
Have a friend
I use it now. My kids are grown up, but God, I probably put 20 casts on my kitchen table. I put stitches in everybody in the neighborhood when my kids were little. Yeah, adults too.
Wow.
Yeah.
I would have kept you very active because I did a lot of damaging things to my body when I was young.
What young male athlete doesn't? Or what athlete doesn't in general, right?
Don't have injuries. Exactly. Yeah.
I think so. What was that, Dr. Robbins?
So I was at Tulane, and I left in 2004, and Katrina came in 2005. And when I was leaving there, we were starting to do this. It was going to be then the largest prospective study looking at female athletes and injuries, because the general consensus is females are more prone to ACL injuries, sport-specific, whatever. But since then, there's been proprioceptive training, and that rate's coming down. But anyway, we were doing hormone levels and pre-strength testing on every female coming into the Tulane athletic system when they walked in the door to have a normative data. And then if they got injured, we'd have their baseline. And then Katrina came and all the data was lost and whatever. And so anyway, that would have been a cool study, but never happened. But anyway.
Impressive. So my last question will be, for my knee instability and the kind of mild nerve, and not really inflammation, but kind of like tingliness I'm treating them with wearing a brace and wearing compression sleeves, compression sleeve with compression socks. I am anxious about that having like a long-term impact on my mind, in that like if I wear it all the time, I won't naturally heal. Is that a silly thing to be anxious about?
Well, to say knee instability, that's an easy term to use, but what does it actually mean? Until you start doing those true core body strengthening, isolated leg exercises that are not constrained by machines, Pilates, whatever, until you do that and you get your strength back to normal. Babe, can you check the door? There's VJ, Katya, and Apollo are here. I got to put a cast on Apollo. Thank you. And then with the nerve, you want to make sure your compression sock isn't too high by your knee, because you could actually be putting pressure on your perineal nerve depending on where the tingling is. So it could be actually a double-edged sword. That the compression sock can be part of the problem. Okay, a couple minutes.
Yeah, we'll be done in a second. Okay, cool. Yeah, Socrates. I actually use a lot of knee sleeves after my surgery, and after a while you can wean off. It's good for like keeping warmth and stability and just that sense of security. So it's good.
Feels good.
Exactly.
Yeah. And I wear compression socks every day at work. If I don't wear compression socks at work, I'm a wreck. Like, I've been wearing them for 5 years. I swear by them every day. I put on my compression socks.
Okay, cool.
All right. Last two questions here, and then we're going to hop off because I know you got guests there. So Edwin's coming back. Is the PMAX available? I think that's everybody's mind. Yeah, so no. 2, is it possible to have tibial lengthening? And then, well, he already asked someone earlier, so he just said,
no. He's now saying tibial lengthening after 3 months of consolidation of femur. Probably not. You did it the wrong way, because you may not be able to bend your knee enough after 3 months to put the tibial nail in. That's what it depends on.
So tibia first.
So if you fully bend your knee enough to get the nail in, then yes, you could do tibial lengthening after 5 centimeters of femur lengthening. But I don't know if you will be able to, but in theory, it's possible.
Got it. Okay. Let's see. Then this was the question about Brett. He says, how many centimeters did he do? He actually texted me after he went back home, and actually last night, and he did 2 lengthenings with Dr. Robbins here, and he did a full 6 inches. He went from 5'7", and he finished off at 6'1". He fought for every bit of it. So that's huge. All right, cool.
Hey guys, I'm finishing up doing that.
All right, guys. And then
we didn't talk about books.
I was just about to ask you. Tell us what books you're reading and what's for dinner. That's.
I wrote down my list. We have to do like our book club.
Yeah,
okay.
Our book club.
Last night when I was running, I did John Steinbeck of Mice and Men, so 1917, whatever, quick book. I just read a really cool book called Into. Hold on 1 second. Hey, Vij, can you either take Apollo there? Yeah, I'm on a live thing. Into Unknown Skies. It's a story about the first race around the world in the 1920s. There was an American team, an Argentinian team, a French team, a British team to be the first team to circumnavigate the globe in open cockpit biplanes that went 70 miles an hour, 150 days, going 600 miles a day, 50 feet above the water, through blizzards, standing up with propellant, like unbelievable. So that was a cool story. So Unknown Skies is an awesome read. Carl Hyacin, if anybody's watched the show called Bad Monkey, which is on Netflix or Hulu, Vince Vaughn plays the detective. Carl Hyacin wrote the book called Bad Monkey, which I happened to read a couple months ago, but I read the follow-up called Razor Girl. It's just a kind of a throwaway couple 100-page book in Key West, a detective. If anyone's watched The Expanse TV show by James Corey, I read the last book in the series called Leviathan Falls, which is a sci-fi that kind of summarizes, it brings the whole Expanse universe to an end. And then he started a new series. I read a book called Mercy of the Gods, which imagine humanity's in an interstellar war and we lose. What happens to the prisoners? And so it's humanity as prisoners. And then I'm still reading that Material World one we talked about last time about salt and copper and all these things I kind of do. So the first 5 books are all new books in the last 4 weeks, and Material World is still over from last time.
How do you do? You sleep? Like you operate? Like you read books? You cook? You're a father? Like I don't know how he does all this. Like
I don't get it.
Well, 2-hour run at double speed is 4 hours of a book. I drive, I do and that's not podcasts. I probably do 20 hours of podcast a week on there too.
That's
always
insane.
fun. There's always something to learn.
And then what's for dinner?
Oh yeah, so I'm famished. So today I myself ate 2.5 pounds of chicken, chicken breast on the grill, and I made pesto last night. So I had pesto and grill. It was so good. I make really good pesto.
Sounds
It
amazing.
was so good. No carbs.
No
It
carbs.
was so good. That's
I don't know how you do it.
and I
He's
got
probably
the
hungry right
next
now.
squash. I'm going to make.
Sounds
Yeah,
amazing.
I'm going to eat another one. Enough.
You got to take a picture
They're
of
so
your
good.
Halloween feast so that we can have that next time.
Oh, yeah,
Yeah.
I will. And
All
I'll
right.
and have our costumes too. Yeah, and I'll get pictures of Marshall for next one.
Sounds good. Sounds good. All right, guys. Well, thank you so much, Dr. Robbins, for coming on. Thank you guys for your awesome
Thanks,
questions.
Dr. G.
And
Thanks,
until next
thanks,
time, this is an amazing panel. Victor from Cyborg for Life, signing out. See you guys next time.
Take care.